Okay, I had to make sure I hit record so I don't forget. Um, but when we're talking about the introduction, which this one just goes over some terms that people use, what's the purpose of anesthesia, and kind of what you're doing. And what I alluded to yesterday was in a practice, your basic small animal practice, potentially 5 to 7 procedures a day involve some form of anesthesia. Now, like I said, some dogs don't want their nails trimmed. We give them a shot of acepromazine, or we have the owner give acepromazine tablets at home before they come in. Now, there are some animals that are on trazodone. That's not necessarily a sedative. That medication works with their anxiety levels. It's technically like it's called an anxiolytic, or breaks up anxiety. But if they give some type of sedative, or you give a sedative, that's a simple procedure. We're monitoring their levels, and then of course you have full anesthesia. So I'm going to talk about the different terms and what the animal shows, but it's going to be used to sedate them, immobilize them. The other big thing about anesthesia or sedation, we typically want to get muscle relaxation. When you guys get into RAD 2, hopefully next term, those animals are all sedated. One, because it's going to take you guys longer to take x-rays. Two, you want good relaxation so you can stretch the animal, and especially when you do orthopedic radiographs. So a lot of times in a practice, you're going to do awake x-rays. We don't sedate every patient for radiographs, but there are some types of radiographs where they might need immobilization or muscle relaxation. Now, when an animal is sedated, they're not necessarily unconscious. I mean, you can talk to a sedated animal, and sometimes I say their name and their tail wags really slow, or they kind of like lift their head and go, oh, okay. So there's going to be levels of sedation that we can achieve. There's going to be semi-conscious, and that's what I'm talking about. A little bit of history is how we've evolved. If you think about the old movies and they put a rag over the person's face and then they pass out, that's chloroform. That's a liquid that's put on a rag. It's not necessarily controlled because it's on a rag. How much are they going to absorb? How much did you put on the rag? Ether was also used as early as the 1850s. But once we get into, starting in the 1930s, they evolved into injectable barbiturates. So we could give something intravenously to induce anesthesia. We could control the level. And then as we've evolved, all the way up from the 30s to the 90s, we've added different agents. And I will tell you, let's see, I've been at the school, actually it's 3 years this month. 3 years yesterday, I've been back teaching. But when I was in oncology, before I came here, we just got Alfaxin. Alfaxin, oh, teacherversary, yay. I know, I'm so happy to be back. I do love teaching, so I'm glad to be back. But we just got Alfaxin. Alfaxin is alfaxalone, and it had been used in Europe. So a lot of times Europe will get stuff before we do. And so I used it for the first time. So there are new drugs being introduced. Then some drugs are being adjusted. Dexdomitor was changed and a new version came out. So you guys will encounter, they're constantly evolving. And then you always have your old standbys. Acepromazine's been around for a very long time. Okay, we still use it. Valium, a very long time. Ketamine. But then propofol was newer. If you've heard of propofol, or the Michael Jackson drug, propofol was introduced to us when I was at Purdue. So the company brought it and said, here, use this cool new drug. And it was very strange, and they trained us how to use it. And, now it's used routinely throughout the world. So there's a little bit of history there. Also, anesthesia does have there are people that specialize. Obviously, there's one thing, if you're a dork like me now, there's the Academy of Veterinary Technician anesthetists. If you guys remember way back, I think in Tech 1, they talked about you could be a technician specialist. You could choose to specialize and get your VTS. So there is an anesthesia specialty. Hang on, I think I'm getting a pause. Okay. Am I paused? You can hear me okay? Okay. Yeah, I get a little thing. It says internet connection unstable. Hopefully you can hear me now if I'm back to normal. Okay. A little side note, when I was at Purdue and my specialty was anesthesia, I worked in surgery and anesthesia. They came up with the academy. But then I had my daughter, and, you know, it kind of sidelined my getting, so I never got my specialty. There's a lot of work that goes into getting a specialty. I kind of wish I would have at the time, but, you know, it's something that can be pursued. You usually have to work under a board certified anesthesiologist, and you have to do a high level of cases. But there is an agency for techs. There's also veterinary anesthetists. So the Academy of Veterinary Anesthesiologists. There is the Pain Management Association. This website here at the bottom, it says www.vasg.org. It's the Veterinary Anesthesia Analgesia Support Group. It's a great website. I sometimes will refer to it and use it in class, but it has a lot of articles about procedures, epidurals, drugs. So when you're studying, especially when we get into the anesthetic drugs, that website has a lot of good information. So you might take a picture of this, or you might just remember this slide for reference of organizations that you can join. Okay, these are the terms that people use interchangeably when we talk about, you know, anesthesia, when we say that, means literally without feeling. You know, aesthesia or aesthetic is feeling. Anesthesia is without feeling. So when we've achieved anesthesia, the goal is we don't want the animal, we're doing something we don't want them to recognize or feel. Obviously, if they're getting a spay, you don't want them moving, you don't want them reacting. So there's levels we'll talk about. If we're talking about general anesthesia, and if you open this up in the notes page, it has these further definitions for you. That homework that I gave you, you needed to do the vocabulary that is in chapter 1, and then the words I listed for chapter 2. So this might help with some of that vocabulary. But if we have general anesthesia, it is a reversible state of unconsciousness, immobility, muscle relaxation, loss of sensation throughout the entire body. When we're talking about general anesthesia, the whole body is anesthetized. The key here is reversible. That means when you're done with surgery, you can wake them up and bring them back to consciousness, okay? So general anesthesia, when I get into monitoring, we're gonna talk about depth of anesthesia. You know, there's light and there's deep, and obviously there's depth. I usually write on a piece of paper, and let me get that out here for a second. And it looks strange. If you can imagine this picture, okay, when they're alive and completely awake and conscious and can feel everything, then we give them anesthesia. If we give them too much or keep them too deep, we don't want them here, okay? We want to keep them somewhere in this range. Now, if you don't give them a lot of anesthesia, you give them sedation, you're probably gonna be somewhere here. When you completely anesthetize them and you start to give too much, they start to look too deep. And then you turn down your gas, and then they get a little light, and then you turn them back up. So what we do like during a surgery, like a spay or a neuter, is we hover somewhere in this range. When you monitor a patient, okay, you're going to be looking at the vital signs, and the vital signs and the reflexes are going to tell you where you are within this range. Now, like I said, when we talk about sedation, or, you know, you give a dog like acepromazine, you're going to be like up here. They are awake, alive, but they're somewhat asleep. When we give general anesthesia, we get into this range, and the reason we don't give too much is obviously we don't want to completely do this, okay? So I will refer to this when we talk about levels of anesthesia. Some of the terms I'm going to talk about here, analgesia is well, let me talk about surgical anesthesia. Surgical anesthesia, you have to achieve enough level of unconsciousness and immobility so that they do not wake up for the procedure. Analgesia, a lot of the anesthetics provide analgesia, which is pain relief. When we talk about algia, or we talk about pain, analgesia is without pain. So the goal of our anesthetic procedures is to keep them immobile, keep them relaxed, but also achieve analgesia. I will tell you, I will get into drugs later, acepromazine. Acepromazine, they will look very asleep. But I promise you, if they have a broken leg and you go to take an x-ray and you pull that leg, that animal can react. Acepromazine does not give pain relief. It just sedates them. If I give a dog ACE and morphine, I give a sedative and an analgesic. Now they're asleep, or they're sedated, and they're not painful. So there's levels of, you know, sedation, but you should always have an analgesic component if you're doing surgery. Sedation is not necessarily, this is depression and drowsiness. So if they're sedated, they're mentally dull, mentally depressed. That's why we gave them the drug, and they're drowsy. But if they're sedated, they can typically be aroused. You can say their name and they might look up at you, or they might wag their tail. Within sedation, there's light sedation and deep sedation. A tablet of ACE for a nail trim, we're trying to get light sedation. If I give a dog dexdomitor and butorphanol for an x-ray, I want deep sedation. So within the drugs, we can achieve different levels of sedation. And a lot of that is based on the animal and what you're trying to do. Like I said, if a nail trim, I just need them not fighting me as much. If I need to take 3 views of the pelvis in a painful dog, I'm going to need a deeper level of sedation. Sedation and tranquilization is where people get terms confused. So when we're talking about tranquilization, it is a state of calm, drug-induced state of calm. Literally, the patient is reluctant to move, but they are aware but unconcerned about their surroundings. I will tell you, sedation and tranquilization are used sometimes hand in hand. But think about this. If someone says, I'm going to go to the zoo and tranquilize a tiger, they don't say, I'm going to sedate a tiger, if it makes sense. Tranquilization is usually a deeper, it's a more immobilization, a deeper scenario. But one thing I want you guys to understand, and there's things I say that are like my soapbox material, and this is my pet peeve. People will sedate a dog, and people will tranquilize a dog, and they'll have them on a table for like an x-ray, or they'll have them on a table in the treatment room, and they're getting ready to do something, and the dog looks completely asleep. And I've seen people walk away from the animal on the table. You never, ever, ever, ever walk away from a sedated animal on a table without having a hand on them. Had a dog sedated at Purdue, nobody was by the dog. Somebody dropped a metal lid from the prep container. The dog leaped off the table, fell, and I can still to this day hear that dog's skull and jaw hitting the floor. And it's a miracle that dog did not break its skull or break its jaw. So I've seen a dog look completely asleep and then someone make a loud noise, and then all of a sudden the dog comes to and reacts. Whenever I have a dog sedated, I have my hand on them. Okay. I walked even in our, yes, so tranquilization is a little bit deeper than sedation. That's correct. Let's see. But I walked into the treatment room, even at our school, and they had sedated a dog. They were getting ready to do a catheter. Dr. Ritz was drawing up drugs. McClure was working with another patient. I walked in to get something, and 4 students were around this dog, and nobody was looking at the dog. One person was writing on a paper, one person was setting up the dental machine, and I was like, if I would have come in here super loud, that dog could have jumped. And it did happen there once where a dog fell off the table under sedation. You just never know how they're going to react. So you have to have the ability to handle the patient. The other thing that I want to tell you, since I'm talking about sedation and tranquilization, is an animal can respond aggressively sedated and tranquilized. If you give ACE and you do something painful, they might snap or bite when they are sedated. And the problem is when they snap or bite, they are not fully conscious. They don't always let go. I had a coworker, you're fine for people that are having internet issues if you pop in, but I had a coworker, we were recovering a dog, waking up from anesthesia, and he extubated the dog. And the dog was not a nice dog when we anesthetized it. When he pulled the tube, the dog turned and bit his hand and was chomping and would not let go. And this was a big old farm dude. He was a big tough guy when I was at Purdue, and he's yelling and yelling. And I had extra propofol in my pocket that we did not use, so I quickly put it in the catheter, anesthetized him enough where I could open the jaw off his hand. So first of all, when they're sedated, just pay attention to them. They could fall off the table, and if they respond aggressively, remember, they're not quite with it. Most dogs, if they bite and they're kind of a good dog, but they're scared, they kind of snap or bite and let go. When they're sedated, they don't always know what they're doing. So I just say always be cautious. Okay. If we talk about, this should say hypnosis, not hyposis. So sorry for that typo. Hypnosis is a drug-like sleep state. And this impairs them to be able to respond to stimuli. So this is even deeper. I will tell you, propofol is described as a hypnotic agent. When people talk about propofol, they're like, it's a hypnotic. When you give propofol, you will put them in a sleep-like state and they shouldn't respond. Now, eventually the propofol wears off, but when you give propofol, you are putting them in a state where they will not respond to stimulus. They will be anesthetized. And then narcosis is a drug-induced sleep that's given with narcotics. So the difference between hypnosis and narcosis is the drug, okay? Both are a very deep sleep-like state, but narcosis would be if you gave like morphine. Morphine's a narcotic, hydromorphone, fentanyl. Those are all narcotic agents. Hypnosis is induced when you use other drugs like propofol. Somebody mute, please. I'm getting some feedback. All right. Now, a term that we talk about, I get into these 4: local, topical, regional, epidural anesthesia. Local anesthesia is when you will use an agent, say like lidocaine. Like if you've ever gone to the dentist, okay, and you're going to have a root canal, a cavity, and they inject usually lidocaine or a drug called bupivacaine. Now, when they block a nerve, you have a nerve that will supply a chunk or multiple teeth. If you block that nerve, that's called regional anesthesia. You are blocking a whole region of nerves. Now, you are not asleep when you get a cavity filled, but they're going to numb so that you don't feel anything in that area. If you're doing local anesthesia, that's usually deposited in one area, one tooth. Regional would be like blocking a whole set of nerves for multiple. Topical anesthesia would be if you put something, sometimes we can squirt lidocaine on a wound. So if a dog comes in, you'll say it's a dog fight and their leg is like, ripped open from the wound. A lot of times doctors will sometimes just squirt lidocaine before we start cleaning the wound to kind of numb the area. But when you put it on topically, you're putting it on the top. Numbing cream, when we put lidocaine, we squirt lidocaine on cats' vocal cords before we intubate. That's topical. We're not injecting it, we're just putting it on top. And then an epidural we will get into is when you block the back legs. So topical, local, regional, epidural are all when we numb nerves. And a lot of times we do that with anesthesia. Most dogs that have a rear limb fracture or say they have back leg surgery, they will get an epidural and that will block the sensation to a much larger area. So the key that I'm going to talk about here is there's a note at the bottom called balanced anesthesia. What we're going to, the whole purpose of anesthesia is you're using multiple drugs and they maximize the benefit of each drug. And it minimizes the adverse effects. And you get depression, CNS depression, relaxation, analgesia, immobilization. Let me give you my analogy. Okay, I like to use analogies, and maybe a lot of you do not cook, maybe some of you cook. I'm gonna make soup, say, okay? If I decide I'm gonna make soup, but I'm only gonna use salt, that's my only seasoning I'm gonna use, I'm probably gonna have to use quite a bit of salt to make it taste good. So the amount of salt, because I'm only using salt, I'm gonna use a much higher level of salt. Now, what are the side effects of salt? Water retention, you get that dry mouth. Potentially if you have heart issues, you don't wanna have too much sodium. People that have heart issues, they make that like Mrs. Dash or whatever. And what it is it's a blend of spices, and then you don't really have to use salt, or you only use a little bit. So let's say I'm gonna make the soup, but instead I'm gonna use a little bit of salt, a little bit of oregano, a little bit of thyme, a little bit of salt, a little bit of pepper. I'm using multiple spices, but by me using multiple spices, I can decrease the level of those spices and any potential side effect, okay? By me adding all these other herbs, I can decrease the level of salt. Salt is my offensive ingredient. Does that make sense? Hopefully it does. I think about anesthesia as like making soup. Some people are like, we don't want to give a dog too many drugs. That's hogwash, okay? I'm sorry, I'm going to be blunt. It is better for the patient to use multiple anesthetic agents in lower amounts. Like when you give a dog ACE, if you just want to sedate a dog with ACE promazine before surgery, you are going to have to use a decent amount of ACE. If I give ACE and then I give butorphanol with it, I can decrease my level of ACE. And they enhance each other. They act synergistically. ACE gives me sedation. Butorphanol gives me analgesia. Together, I have a sleepy patient that is going to wake up feeling better because I gave them a medicine for pain and I gave them some sedation. So the whole nuts and bolts, the whole thing I'm going to preach in anesthesia is our goal is to do balanced anesthesia. And balance is using multiple agents to achieve everything I want to achieve. Sedation, muscle relaxation, CNS depression, analgesia. Do you see? Amen. Miranda's comment. Yes, and Caleb. So Miranda put a comment, but it was listed as a private comment. I don't know if you guys can see it. It says, so they maximize each other and decrease side effects. That's the amen statement of the day. They enhance each other, and by using multiple agents, I lower them. And what Caleb said, would pain meds also help prevent them from waking up? Yes. So if I have a dog during a surgery and they keep moving or their heart rate keeps going up, what is that telling me? That's telling me they're feeling something. So a lot of times we will give another shot of morphine or butorphanol of a pain med during surgery. Because I'm jumping ahead a little bit, but the inhalants that we give them, isoflurane and sevoflurane, when they inhale the gas, there is no analgesic effects to those drugs. All they are doing is keeping the animal asleep and preventing them from moving. So if you keep having to turn up your inhalant, and if any of you guys are working in a practice and you have a patient you keep turning up and up and up, it means they're feeling something because you keep having to turn them up. The better option is to give them a shot of a pain med like morphine or butorphanol, buprenorphine. And then if you treat their pain, they should be easier to maintain or keep them on a lower level of gas. So both of you had made comments that are like, that's what I'm talking about. I'm going to talk about, we do a whole lecture on pain by itself in anesthesia too. So we talk about different pain techniques. But I will, when I go over the anesthetic agents, one big key thing you have to understand is which agents provide analgesia and which ones do not. And I stress that every drug I go through, I talk about the pros and cons of the drugs. What are the common side effects? What are the benefits? Acepromazine, I love, but it does not treat pain. So I know a dog on acepromazine can act out. Riley asked a question, what would be ideal for an emergency situation? I will tell you, when you work emergency, we had a dog that came in that was absolutely attacked by the neighbor dog. I mean, it was, I don't want to say shredded to bits, but this poor dog came in and it was screaming and it had been attacked. I've talked about this case, the German Shepherd that lived next, the dog was it was a beagle in an e-collar, and the German Shepherd next door reached over the fence, grabbed the e-collar of the beagle and pulled it into its yard and attacked it. When it came rushing in to us, there's blood and there's lacerations and the dog is crying. I don't have time to be like, so how's your dog? Let's get some blood work. I want to give it some drugs. Like, this dog is screaming. The nice thing about when I get into opioids, hydromorphone is fairly safe. Midazolam is fairly safe. So that dog, we gave a slug of hydromorphone right off the bat because we're like, we need to treat this dog's pain so we can even examine it. So we gave a shot right away of hydromorphone and we gave a little bit of midazolam. Both have minimal side effects. So Riley, we have kind of a list of drugs that we will sometimes reach for because we know that they're safer when we don't know much about the patient. And in that situation, like I said, we got to do something now. We don't have time to wait for blood work and talk to the owner and get a history. So sometimes there's a group of drugs that we'll talk about. So hopefully that answers your question. And I know I spoke a lot just on one slide, but I want you guys to understand what we're going to be talking about. And understanding that the goal of anesthesia, every drug comes with side effects. Every drug. And what I used to say day one to my students is, and I still say it, but every drug I'm going to teach you about can kill your patient. Every single drug. But we're going to put it into the hands of trained people. I train you about the different drugs. Your veterinarian is trained about different drugs. And we're going to choose drugs safely, and we're going to choose dosages safely. So you can use every drug safely, but you have to respect what every drug can do to that patient. And that's why I talked yesterday about being prepared for anesthesia. You want to go into the procedure understanding the drugs you're using so I can anticipate side effects. Okay. One thing you guys will hear me say, and I want to clear up some confusion because I get this question too. I will say, I pick this drug, I choose this drug. When I was working in my practice before tech school and I was on the job trained tech, and then when I was at Purdue working under an anesthesiologist, we had protocols. My boss of the one practice in Chicago had a list of anesthesia protocols. At Purdue, we had a list of anesthesia protocols. They were written by the DVM, okay? I was a technician. I said I was going to give this dog ace-butorphanol. At Purdue, I'm like, I'm going to use propofol. Now, am I choosing the drug? Yes, but they've been prescribed by a doctor in charge. So when the doctor gets comfortable with you with anesthesia, and when you get used to the practice, a lot of times the veterinarian has already told you, these patients are going to get these drugs, these patients are going to get these drugs, these are my dosages. Now, I always have patients that fall out of that normal, and I would go to the doctor and say, do you want morphine in this dog? Do you want propofol? Would you rather me use Ketval? I hear a murmur. So I am not prescribing. Technicians are not supposed to prescribe. But when you work with anesthesia protocols, the doctor has listed protocols. Dr. Ritz on day one of surgery, you guys get a list of protocols, dog protocols, cat protocols, okay? You will know what drugs you are using when you go into rotation. If you have a dog patient that day, you're going to be using these drugs. If you have a cat spay that day, you're going to use these drugs. So you will know the night before what drugs you should be reviewing. What are the side effects of butorphanol in a cat? What are the side effects of ketamine in a cat? Okay? So we're going to build, but whenever I use that terminology, I don't want you guys to think I was doing something I wasn't supposed to do. The veterinarian and the anesthesiologist I worked for, and my anesthesiologist gave me training. So I was trained to know what he wanted, and I was trained to carry out his protocols. We were always in communication. I just don't want to create confusion. So realize your doctor is going to tell you what to do. Your doctor is going to give you guidance, and then you're going to carry out the plan. So if we're talking about anesthesia, when we're talking about the loss of sensation, and we're going to talk about this CNS depression, the goal of sedation and anesthesia is to depress the central nervous system. The central nervous system is what responds to pain, that responds to noxious stimulus. The central nervous system controls the muscles, okay? If I don't want my patient to move, if I don't want my patient to react, if I want to be able to do something painful without them feeling, I have to control the central nervous system. All of the anesthetics in different levels affect the central nervous system. Let me give you, okay, I just talked about lidocaine, or I talked about a local block. If I do a ring block for a declaw, I put lidocaine in a ring around the carpus, okay? When you go to remove the claw, you do something painful. Normally that signal is sent up a sensory nerve. The brain says that hurts, sends a motor signal, and they pull the paw. Lidocaine blocks the sodium channels from opening, and it prevents that signal to be transmitted. If the brain never gets a signal sent to it, does it detect something painful and move the paw? I'm gonna wait for somebody to respond. If I give lidocaine and I block the sodium channel from transmitting us, exactly. It's kind of like, are you in the forest? Does a tree fall, make a sound? Well, that's not quite exactly the same. If I do something painful, okay, if I block the sodium channel, the signal is never sent. That is how local anesthetics work. Okay, different anesthetics work at a different level of the central nervous system. But what we're trying to do is control the central nervous system's ability to detect messages or react to messages. Okay, so I'm going to get into that. again, general anesthesia is technically a reversible state of unconsciousness. What you have to know about general anesthesia, and it's in the notes below, is the patient cannot be aroused by a painful stimulus. If they are anesthetized and Dr. Ritz goes to open the abdomen during a spay, you don't want them feeling that and reacting to that. So they have to be at a level of unconsciousness so they don't consciously recognize something painful is happening to them. Now, this is typically general anesthesia is used for general surgery or something that's extremely painful. So we usually go into general anesthesia. We need the patient completely asleep and not reacting. One thing that I ask, and I think is a question on the homework or that I've asked before, is give me an example of something that's appropriate for the level of procedure. Now, this doesn't completely line up, but let me give you an example. Grooming, okay? If you work in a general practice, I don't know how many times I had the old lady bring in her cat. It was a long-haired cat, and it's all matted. I mean, she didn't take care of it. The cat doesn't groom itself, but the cat is a pistol, okay? Well, first of all, I'm probably not gonna be able to brush out that cat. We probably need to do a shave down. Acepromazine was a perfect tranquilizer for that to get grooming done. If I want an animal immobile for a grooming, I can give them acepromazine. If I want to diagnostic imaging, so if I want to take an x-ray, a lot of times you're going to need muscle relaxation and immobility. Surgery, I obviously need them unconscious. Wound care. Now, wound care can be, I mean, when I talked about that dog that was attacked, that came in with multiple lacerations, we had to anesthetize that dog. He had multiple lacerations. Sometimes a dog just kind of like cuts itself on the fence, and we give a little local anesthetic, a little sedative, and we sew it up. So wound care is going to depend on, you know, if it's a hit by car and we've got like major road rash, that's different than a dog just cuts its paw like on the sidewalk or, you know. But I want you to be able to tell me, if I say general anesthesia is for, or surgical anesthesia is for surgery like a spay or neuter. If I want to trim nails or clip some mats, that might just be sedation. Tranquilization is when we get into capturing wild animals, and that's a deeper level, okay? Now, there's a note under this slide. It says the effect of anesthesia does not always include loss of consciousness. Again, if I have a dog sedated or tranquilized, they have a depressed level of consciousness, but again, if you do something painful or they hear a loud noise, they might lift their head. If they hear their name, they might wag their tail. Okay, so that means they're still in there. They can still process pain, they can still process sound, and they can react. Now, they're probably gonna react slower, but they can still react. And that's why I said a lot of people just give like ACE or something for an x-ray. But if the dog is painful and you go to crank on that leg for an x-ray, I've seen those dogs try to reach up and snap. And if you're not expecting it, you could potentially get bit. And like I said, it sucks to be bit by something that's sedated. So I always have a hand on the head. I'm always, when I go to pull a leg, I always kind of look at their head and be like, does this hurt? Do you feel it? Okay. So be familiar with times when we would do this. And then obviously surgical anesthesia they're going to be general anesthesia, but they're going to have deep muscle relaxation and they should not feel pain. And the ultimate goal here is we do not want movement during the procedure. Okay. Let me give you an example. Okay. This is a very important slide. So this is a better version of this. Okay. This is my quick 2-second version, but I wanted to use that real quick to explain something. Here we have an animal awake. We've got the light sedation, moderate, deep. Hypnosis and narcosis. There's something I'm going to talk about. Well, we talk about later. I'm going to talk about these levels of anesthesia. Okay. When they're awake, there's something called stage 1. Then there's stage 2. Then there's stage 3. When we get into stage 3, that is getting very deep. Now, stage 2 is something called the excitement phase. When you pass through hypnosis, narcosis, you're going from awake to completely asleep. In that stage, they can react sometimes not how we want them to. That's when they sometimes cry out or twitch or paddle when they're getting under anesthesia. And I'm going to talk about that when we get into monitoring. But what we're trying to do is avoid getting down here. So again, light sedation, nail trim. Okay, moderate sedation, maybe nail trim, vaccines, draw blood, on that awful patient that wants to kill you. Deep sedation, we got to take a lot of orthopedic x-rays. Patient's very painful. When we are anesthetizing them, we travel through hypnosis and narcosis, and then here is when we get into general anesthesia. We've passed through hypnosis. This is when they're asleep. Light anesthesia, they could potentially still react. One thing I'm going to talk about in monitoring, this might help make sense, is when a dog's on a table, they're laying down. Sometimes I'm the anesthetist, I pinch in between their toes. And I use my nails and I pinch hard. Okay, if my dog's asleep and then all of a sudden he goes like this, when I start pinching his toes, that's the withdrawal reflex. That patient is not asleep enough. Dr. Ritz is about to come in and spay. If a dog feels this, the dog is going to feel if she puts a blade to the skin. I know I'm going to turn that patient up to get them into surgical anesthesia. Okay? Now, if I turn that patient up and I leave them there, and then all of a sudden my dog's heart rate starts dropping, they're getting colder, respiratory rate starts dropping, all of a sudden I pinch their toe and they're just sitting there, then I'm like, are they getting too deep? Because now all of their vital signs and their reflexes are showing me that they're not responding. That's when I turn a patient down and I try to bring them up. So when I said we like to live here, when you're doing a surgery procedure, you want to live here. Okay? When you sedate an animal for grooming, an x-ray, nail trim, you're probably somewhere up here. And again, there's always going to be those patients that my coworker had a nasty mastiff when I worked in Anderson. The dog was awful. The whole practice was scared of this dog. Just to do a nail trim and to clean his ears, we one time had to give him 3 doses of sedation. Because we gave him 1 dose, we'd go back to pull him out, and he would still growl and lift his head. We're like, oh, give him some more. And then we just keep layering it. Surgical anesthesia, Michaela, it depends on what drugs you're using, how long it takes to achieve surgical anesthesia. It can take 20 minutes or so to get deep enough to achieve that effect. So I'm going to get into that when I talk about how we give anesthetics and whatnot. But I want to stop here today because I know I'm getting to the end of my time. And I want to get a little bit more into this chart. Do you have any questions about today? And Michaela, that'll make sense as we start to talk about more drugs, how long it takes. Okay. Does anybody have any questions?